Good morning, everyone. Thank you so much for being here in this Boomy Health Talks on this second version this year. We will just wait for a minute to make sure that those attendees who have been waiting can join us. Okay, so I want to reiterate good morning, everyone. Today we're going to have a very interesting topic to discuss, which is childhood leukemia. This is one of the diseases which is very common among children. And today we have one of our allies that is extremely important, which is the Hospital Señor in Barcelona, who will be leading this session, specifically Dr. Maria Antonia Ruiz Cobot. Next slide. Before we begin with this session, just to tell you a little bit that the sessions will be done in the three languages. On the bottom part of the right side, you can switch to the language of preference. The session is interpreted simultaneously, and these are the indications, instructions. So how to use the interpretation for the pertinent language on the control panel on the bottom part to the right, you can hit the globe, which is interpretation, and then you can select the original language, which is going to be Spanish, and then you can hear the simultaneous interpretation on in English or in Portuguese. Next slide, please. Next. Okay, so before I introduce myself, on the bottom right part of the screen, you will find the Q&A button where you can ask your questions or your concerns about this topic. You can hit click on the Q&A session or in the Q&A, and you can send your questions so that we can respond to those questions once the doctor completes her presentation. My name is Dr. Miguel Dewey. I'm currently in Bumi as part of the all the health programs. I have some certifications on biomedical IT. And next slide. I want to introduce you to Dr. Maria Antonia Ruiz Cobo. Fernando, I don't know if you want to say a few words. Thank you so much, and greetings to the whole forum. I think that I am very pleased to greet you from Mexico today. I'm in a commercial mission. My name is Fernando Pancino, pediatrician and development director from the Children's Hospital, which is the entity hosting us here. We're very pleased about this alliance here and the journey that we will be traveling here together with Maria Antonia, and who will explain what that you will hear in a message that will have to do with your concerns. And after this session, I am very pleased to be here. Thank you for me for the opportunity to be here with you. Thank you, Fernando. Without any further ado, I want to introduce you to Maria Antonia Ruiz She's a hematologist. Um, with a specific, especially focused on leukemia, which is the topic that is addressing that is bringing us here today. She has been working since 2023. She's part she has been part of the leukemia, lymphoma, and CAR T unit at the Hospital Joan de Dieu in Barcelona. In addition, she has an official university master's degree in advances in pediatric oncology and hematology since 2024, which has allowed her to deepen in the comprehensive and specialized approach to this pathology. She teaches this master's degree and collaborates in the training programs as well as in the university final project. So we have the best specialists here to talk about this. So I want to welcome you, Doctor. Thank you for participating in these Boomy Health Talks. And thank you, Fernando, for allowing us to do this conversation. And the floor is yours. Thank you so much for the introduction. And I'm very pleased to be part of these conversations, these talks. Good morning, everyone. It's good afternoon here. So we're gonna have a session on pediatric acute leukemia with clear concepts and without going or delving into the medical aspect at some point in time. You can stop me and you can ask any questions as you please. This is an introduction in terms of what do we need to know about childhood leukemia. This is the index. To begin with, it is important to know that childhood cancer is a rare disease, but unfortunately, this is the main cause of death globally, and this is not out of chance. Now, in terms of the incidence, approximately nearly 300,000, 400,000 cases per year, especially in low-income countries. As to leukemia, it is important to know that it is quite common. This is a rare disease, and that this leukemia represents 1/3 of childhood cancer. So as you can see in the on the diagram to the left, it is much it is the acute lymphoblastic and lymphomas. They have a lower incidence, and this incidence changes through the pediatric life. As you on the right side, you can see that at 2 or 3 years of age, this is the highest incidence of leukemia. There are other types of cancers which disappear throughout time. An interesting question in terms of that it is often asked because I mean it is compared with the adult cancer. It is important to know, as I normally explain to people, that they have nothing to do. The pediatric cancer with adult cancer, they're completely different, and this is why there are different we this is why we want to do specific treatments for each child in a general way so that you can understand the reason why of this reason. When you have a cancer in an adult, we have a somatic mature cell that is accumulating mutation throughout time. It accumulates a lot of mutations, and at a certain point in time, it develops this tumor. In the case of the child, this mutation is in the is in a less developed cell, and then there's a mutation, and that's where we can develop the child cancer. So this mutation of the precursor, this is what we call a development cancer. So this is why it is completely different to the adult cancer, and in the vast majority of cases we don't have ways to prevent this cancer, as is the case as in the cancer of adults. This is something that will be better understood when we talk about the origin. The vast majority of pediatric cancer is unknown. We cannot know what has happened to to have cancer, and we we normally say that this is out of bad luck and this is something that you have, and that's it. Only from more than 5% of the pediatric cancer have are inherited. They may be syndrome, some patients with a predisposition to cancer, such as Down syndrome, which have this type of mutation in the sperm or and there will be some predisposition, and in a minimum quantity, which develops around 1%, which have to do with the environmental. The typical case of Chernobyl, this is the classic example where these children developed a secondary gender, but the vast majority is uh, uh, is of an unknown origin. Now, in terms of the clinical manifestation that we need to consider when we have a child who may have a leukemia, I have divided these in different parts. There's a constitution chart that they have the weight loss. Children do not want to play. They do not want to eat, and the secondary to these the secondary ones to this invasion is that the malign um are within there is a bone marrow invasion, and therefore the other cells cannot perform the function. This leads to anemia due to lack of red cells. We have a low number of platelets. There's more blooding with any trauma or even with no trauma. Uh, we have the neutropenia, which is the defense of the body. There are repetitive infections and bone pain. So this is why the bone marrow invasion may imply some pain on the legs. But there are other less symptoms. For example, if you have a mediastinal mass, if there is, you may have skin lesions, which you don't know where they're coming from. If there is an affectation of the brain, there may be some symptoms associated. But I think that this is the invasion of the bone marrow, which is represented on the drawing. This is something that may be a wake-up call when we have a child on a medical appointment, for the same reasons. Now, in terms of the diagnosis of leukemia in general, we need to look at the origin. When children come to the clinic, if we can collect a blood sample, and we look into the cells, these cells that are immature, that may lead to an acute leukemia. To do a full diagnosis, we need to go to the bone marrow, which is where the disease begins. And when it is filled, these cells are pulled into the regular blood. You can see like a crest. So we take this part of the bone, we take this liquid to be analyzed through several process. The cytology and the color diagram. This is the flow cytology, which is a technique that indicates which is the type of leukemia that they have. And then we do a genetic study, and we look at the mutation. We try to find out what's the mutation that led to this. We normally take a liquid from the bone marrow. This is done on the back, and we see if the cells are going there. This is like a sanctuary. They have the capacity to go through this barrier to get these central nervous system and cause this type of system of symptoms. It's just for you to have an idea of leukemia. The survival rate is very good. There is an 85% survival rate. As you can see, we can see 92%. It has several characteristics. So what's this prognosis? Why cannot we cure? Why do we have children who do not too good. And the age is a prognosis factor. The leukocytes or the white cells, the more they have, the leukemia will be worse. That this is something essential in leukemia in response to the treatment. The leukemia has to respond to the standard process and genetics, which is a boom at development of leukemia, both myeloid and lymphoblastic, which indicate what some leukemias are worse than others. So what's important? What are the challenges that we have as oncologists? These I mean, it is so heterogeneous that it is impossible to know why things are happening, and this is a major challenge we have, and why there is a relapse. When there's a relapse on leukemia, the survival decreases to 30%. So this is a major challenge. This is a mechanism of relapse and resistance in order to improve these general survival during relapse. So in terms of leukemia, we have a we have the acute lymphoblastic leukemia, which is derived from the lymphoid precursor PRT, and this represents 80% of acute leukemia. It takes place from 1 to 4 years of age. In a standard way, the treatment will last 2 years, and the cure rate will be nearly 90%. The LLAB is more frequent, 85% of the children, and T is much more is less common. We have mediastinal adenopathy. In general terms, in order for us to understand the treatment of a leukemia, is the chemotherapy, intensive chemotherapy, which may last 2 years for polychemotherapy. And so we have an induction. So what I want to do with this chemotherapy is to kill it. I want to get rid of that of the disease. So this is the induction treatment, which is intensive. Then there's a consolidation in order to get to the extramedullary tissues. And then we will have to do a reinduction. We have to induce, and we will reduce this risk of lymphoblastic leukemia recurrence. And then maintenance. Children can come to the hospital during the day, and this is essential to avoid relapse. So so we're supporting children and the family for approximately 2 years. Now, thanks after learning about leukemia and to know how genetics plays a significant role. This is something that we have learned throughout the years. We're currently doing in our hospital. We're doing a clinical assay called All Together, which is a chemotherapy adapted to every therapy. So we need to adapt this to the every child. So what do we do with this? We we want to we want to overtreat those leukemia because we used to treat them pretty much the same way, or to treat more those who will require this to avoid relapse. So this is why we avoid the toxicity and because we're perhaps providing more toxicity, and to incorporate immunotherapy and to be able to provide targeted therapies. Now, in terms of the myeloid, ma this is less frequent. It is more frequent in adults, and uh, and in the first year of life. So this is a different side. This is to a double hit, random trial in order to determine if you have this type of leukemia, and the treatment is much more intensive but shorter. It lasts 8 months of a super intensive chemotherapy, and and this it will include two, three consolidation depending on the risk. And this is the protocol that we have used. And this is why we cure 70%. And if there's a relapse, the prognosis will decrease significantly. Now, we also have a new protocol. This new protocol has been improved and it has been adjusted to based on the risk, given the knowledge that we have on the molecular biology to improve the survival results. We have implemented a chip master protocol. We're not getting rid of chemotherapy. We continue with that, but we add the new immunotherapy medication depending on the genetics, and then we adapt the treatment to leukemia. It is important to talk about immunotherapy when we talk about lymphoblastic leukemia. The first thing that you think of is immunotherapy. This is the major outbreak, the major fans of this. In this case, we have heard about the blinatumomab and the GAR therapy. These are antibodies aimed at these mailing cells, and this is the revolution of the lymphoblastic cells, especially B. I'm going to talk about the most important medications that have proven us to be effective. One is blinatumomab. This is an antibody. Um, these these addresses the different types of um, the different type of endogenous T cells, and it has proven to be very positive with these BC. 19 CD19 positive, and in pediatrics we are a little bit behind in terms of the acceptance or approval of this type of medication. It's been approved by the FDA together with first line chemotherapy and also for kids who have certain type of disease or illness. This is a subtype of leukemia which is different. Um, we also have we also have Interfant, which is a clinical assay. The the inotuzumab, it's located in lymphocytes B, and just like the prior one, is showing an increase in the survival rate and also and it is good to avoid the relapse. It's been approved for pediatrics pediatric processes, and it is also used not on the way, but also on the first relapse for patients above 1 year. We already have a clinical assay where these kids with the CD22 positive in a first relapse of high risk, we do the treatment and they can be applied these medication against intensive chemotherapy. I'm going to play a video, which is the immunotherapy, which is the CAR therapy, so that you can understand this well. Sorry. The CAR therapy takes a lymphocyte from the patient. We get it, and through handling or manipulation, we take a lentivirus and to mark. This is like an antibody and it goes. I'm sorry, I don't know why the video is not loading, and there is and it can kill the disease. So this is the major revolution, but what's the issue that we have? What's the inconvenience? This is a long process. This is not a medication that we have elaborated as others. This is a medication that needs to go through a process. So the first, it requires a medical consultation, and then we need to get these leukophoresis. I get these lymphocytes. I take them to the lab. I an expansion and I modify them. I include this receiver or receptor, and it takes 1 month. After 1 month, I can apply this to the patient. In this month of the month, this child has to go through intensive chemotherapy, and they have to withstand it because they need to have a very good general condition, and the leukemia doesn't have to progress while we conduct this process. Now, in terms, we also have this is a okay. We also have the card, which is for lymphoblastic B of a pediatric patient. Now with card, we have several of those in our hospital, which are anti-CD19. But in the first relapse, in an extramedullary relapse, we also have a CAR T dual, which is in Hospital La Paz, and there's a core all, which is against the CD1A, and then there's another one against the CD7. As to the myeloid, I'm not going to go into the details. It's a huge world with a lot of medications and a lot of targets with a very difficult process to address. I'm going to talk about a couple of them which have proven their prescription in pediatric patients. The first one attacks CD33, and this medication has been approved by the FDA. It has been approved by AENA, and it's being used in children below the age of 15. We are requesting, as indicated, and we also have the protocol, which is doing a randomization in all the different pediatric in the new patients who in a random process from to provide gentusumab. So there are many medications that are trying to increase this prognosis and to avoid myeloid in relapse. There's a survival rate of less than 40%. So the idea is to stop these tumor DNA cycle. So we'll also have venetoclax and azacitidine, and they're also being used with intermediate results in this type of leukemia. Another case in the case, we also have the FLT3 inhibitors, which uh, which confer a bad prognosis. They are harder to cure. We've seen that they are associated to chemotherapy. If we apply these FLT3 inhibitors, we can increase survival, and then we can decrease side effects. We have gilteritinib. They will go directly to they will get these type of chemotherapy, a medication that will be a revolution that will require a margin in these type of processes that will target. We also have KMT2A, which have a bad prognosis. They can inhibit these molecule, and they can lead to a correct this differentiation of the cell, of the tumor cell. There's a pediatrician there. It's in the Princess Maxima, and it can get out of indication or prescription in some of the cases. The so this is quite an extensive world. So this is like a summary. The childhood cancer is a very heterogeneous pathology, very different, given the different subtypes and the children and the mutation. They all behave differently, and leukemia is the most frequent in among children. So we have to focus our efforts to cure these children. So this is the major cause of infant mortality, second to disease, and the advances that we're currently doing in understanding leukemia or genetics, we can elaborate multiple targets to develop more specific therapies. It's not, it is not to ensure that the chemotherapy will disappear. It is less toxic than chemotherapy, and there we still need a lot of clinical assays. We shouldn't mimic the adult cancer because they have nothing to do. So thank you so much for your attention. If you have any questions, thank you, doctor. That was an interesting. Thank you so much. Thank you, doctor, for your presentation. To the attendees, you on the bottom part of you have Q&A button, so you can raise your concerns or your questions in this platform. So as we get your questions, I'm going I'm going to act as a father. Oh my God, that's going to be difficult. What are the alarm signs? I mean, at the end of the day, the symptoms are can take place for different diseases, which are much more common than leukemia, which are the wake-up calls that will lead me to take my child to an oncologist or a pediatrician in order to act in due time and perhaps not waiting for greater complications to take place among the children. Acute leukemia, as you have in this is a cancer that takes place. These are children who are very good, and then all of a sudden they're not good. So this is since this is not something that we can think of if our child has fever, but I do think that these, I mean, if we have several symptoms, if we have children with continuous fever, and if there's nothing specific, or if I have not I don't have any problems on my ears. And if these are children who are not playing anymore, or if they have bleeding, if without any type of without hurting themselves, if they're tired, this is alarming if this remains for a period of time. So it will be shocking. I mean, those symptoms together and bone pain. Some kids complain about pain, and that's something that's a wake up call. Those are, I mean, you can tell, and the consultation that this child is going through something, right? To the attendees, please use the Q&A. The first question. Why do we have more incidents of this type of leukemia in low income countries? In general terms, we know that the origin is unknown. Low income countries, there is more. I mean, if you have a component of any type of syndrome or predisposition to cancer, or if there is cancer in your family, will propagate because these are because parents are maybe from the same family in many of these cases. It is also true that, like in Chernobyl, or radiation, or being exposed to health conditions that's even worse in low income countries. There are less controls and so on. So therefore, people can have more I mean, people are prone to get cancer. I mean, there are solid cancers which have other predispositions, which have more unknown causes. Leukemia is normally unknown in terms of the origin. At the end of the day, there are no children. I mean, for some children, we do not know the causes as to why they have this type of cancer. There's an interesting question. This is a very specific case that can apply to other. This is a 9-year-old child, and what's the possibility for this child to relapse? This depends on the type. The type, the risk of leukemia relapse implies the type of leukemia. Depends on the type of leukemia. Now, within this, it's genetics. There are genetics where the relapse risk is higher. So this is why we need to do a more intensive treatment to begin with. Unfortunately, in the oncologist, there's something that we do not take into account. We do not know the reason for this relapse. It is hard for this to be controlled. Now, in terms of what happens, there is more intensive chemotherapy because there's an increased risk. But in other occasions, we don't know the reason to it. And this is out of curiosity. When you have a child that has been cured and that is doing really good, is there any risk to have any hematology cancer in the adult age? There is more risk of having a secondary leukemia after the treatment. And this may take many years. In the first year, this person may have a relapse, but these medications are toxic. So I apply a chemotherapy can affect the malign and the benign thing. So this is why it is toxic. So instead of the stem cell can age before time. So this aging of the cells may lead to a secondary myeloid treatment. Interesting. Is there any restriction in the patient to receive an I would say in the case of the CAR therapy, what you do at the end of the day, you insert this. I mean, you insert a cell and there's a war within the body. That's why they are affected. So there have to be good conditions. There shouldn't be an infection or a severe infection or a cardiac or a heart condition or a pulmonary condition. So there we need to have minimum conditions in order to receive this treatment. I don't know if you're referring to this. I would say yes, that could be the question. Now, the following question, up to what stage when I mean, there may be lack of knowledge of the symptoms. Is it possible to provide care for a successful treatment? What happens if we can postpone this treatment? Is it possible to treat positively the treatment if it is not taken care in due time? Leukemia doesn't have metastases, which is the concept of an adult. There's no metastases, so you can come 2 days before or 2 days after. The prognosis, this will depend on the leukemia. It doesn't matter if it was diagnosed 2 days or 3 days before or 3 days after. Great. And I want to expand a little bit. How can we feed a child with leukemia with the chemotherapy or immunotherapy treatment? And when the child ends the therapy, what will be the lifestyle of this child? How can we take care? Can this child eat as usual? Can they exercise the way they did? What will be the day-to-day activity of this child during and after the treatment? Well, they are on active treatment with chemotherapy, where they have low defense, or which is something that we need to defend. We need to make sure that they do not get any infections. They can get infections because we all live with bacteria, which are leading to these infections. But we need to avoid these external infections. Now, in terms of food, it's like when a woman is pregnant, a food has to be washed. You should try to avoid eating on the street. You don't know what you're being fed, just to to avoid salmonella, listeria, not eating any raw material, and avoid McDonald's type food. Now, when in the maintenance phase, when they are in maintenance, they go back to their normal life. They go back to school, they go swimming, they go to play soccer, and they have a catheter, and they will have it for a while. And they may end up tired, and if they cannot, if they cannot play a football or soccer match, they should play just half of it. What medical factors will determine that the disease should be treated with chemotherapy instead of surgery or a transplant? What will differentiate this type of treatment? Leukemia is a liquid tumor. This is not something that we can cure with a surgery. The tumor is in the blood, so you have it throughout your body. So the metastasis disappears because you have cancer all over your body. You have it in your blood. So the treatment of blood is chemotherapy. There's no other way, and it cannot be a bone marrow transplant. But perhaps to get rid of we need to consolidate. There are leukemia. This is it is not. I can consolidate and change your bone marrow. I need to get rid of your disease. I need to kill the cell that is hurting you, so that so that you can avoid um, uh, your bone marrow from coming back again. There's a specific question: how effective is daunorubicin in leukemia treatment based on your? That depends on the type of leukemia, but the best treatment is chemotherapy. The main medication in chemotherapy for induction. It is true that a cardiotoxic medication, there are new protocols that were that like the altogether we know that the lymphoblastic B leukemia can do good in terms of genetics. But they shouldn't get that type of process because this implies a lot of toxicity, but it will not add it will not lead to curing. So this is something that we're adapting at this time. There's also a question here, which is essential, because the lymphoblastic acute leukemia has it been associated with any viral infection? Yes, there are some infections that may lead to a mutation in the cell and lead to a leukemia. It is not common, but it occurs. So we have to be attentive to that. As you mentioned at the beginning, leukemia, I mean, this type of cancer in children is unknown. Can it this be related to the genetics or to the environment? What I have mentioned, I speak about Chernobyl. People are familiar with it. There are a series of radiations that may lead to a mutation in the cells, which may lead to cancer. But the incidence is less than 1%. But these are cases that have truly taken place. It's less than 1%. Apologies, we had a situation with my internet. There are a couple of questions here. They want to express their gratitude for your presentation. How can you differentiate these type of symptoms? It is not easy to differentiate most of the time. Your bone marrow, the aplasia, it's because your bone marrow is not working. It's like as if it were empty, and it won't work. And leukemia, it is not, it can do it because the bad cells are gaining more space, so you don't have any positive cells. So in the vast majority of symptoms you cannot differentiate this. Now, and talking about, I would say that this type of disease is very rare. What are the causes? What are the symptoms? Is child leukemia is child leukemia something that you inherit? Is there is something that you inherit un, unless the parent had predisposition to to cancer? If you have a genetic disease that can lead you to cancer, I mean, you also have a predisposition, but the cancer is not something that you inherit in this case. There are three questions that are really interesting because they truly have to do with this. What's the prognosis? What are the factors of a better prognosis for a child with leukemia? We already spoke about the treatment and the quality of life. Is it possible to have full recovery without any relapse? The prognosis, this is what I explained at the beginning. Leukemia has a prognosis, and one of them is the treatment to the treatment. The leukemia has to respond to leukemia in the first month. It is not the fact that you're cured, because there are many diseases, but in general terms, at 1 month after, you shouldn't have leukemia. So the response The response to the treatment is also important. If you have a B or T, this will also indicate the prognosis, your age. Uh, if you're above or below 1 year of age, when you come to the ER, you have 400,000 black white cells. You know that the prognosis is worst compared to a normal count of cells. Now, the adverse genetics, you need to try to determine what's the mutation to know what has led to this leukemia. So altogether, will give you a prognosis. Now, in terms of the quality, the full recovery, this is not something that you can guarantee. There are leukemia with higher risk of relapse compared to others, and this may lead to a worse prognosis. It is not the same when you diagnose it compared to when there's a relapse. The more they escape the treatment, they become slower, and then it is harder to cure. I mean, saying that they will never have a relapse, nobody can say that. This, that's true. Which are the symptoms that I think that this is one of the I think that this is one of the questions that we responded like the genetic study is important. It is specific for every child. This is valid for solid tumors. Is there any way to do a screening to determine if a person can have leukemia or um I cannot talk about solid tumors, but in terms of leukemia, there's no specific genetic study done in the pediatric scenario to do it. We do know that if there's we can determine if there's predisposition, but you do not know if it will be developed. There is more risk, and in the general population, there's nothing that could avoid the development of leukemia. Okay, thank you. All these treatments are accepted by the FDA. Yes, they have to be accepted. The FDA and EMA have to approve it in order to be approved. So this is why they are subjected to clinical assays. Uh, these clinical assays begin with the adults and then with the younger patients until the 15 years of age. But in children, it is very difficult to do a clinical assay for a very specific indication. But there are some medications that are not approved, and some medications are approved in the U.S. and not in Europe, and they can be obtained in a different environment because they have proven to be positive for this type of treatment. So thank you, doctor, for such an interesting conversation. It's been so interesting and enlightening for everyone. I think that at the end of the day, this is what we want to convey to all our allies. And then finally, I don't know if you have any final remarks in terms of leukemia, how difficult it is to go through it as a parent or as a child. It should be. I guess I imagine this is complicated. What would be the best advice if you go through this process? If you were told that your child has leukemia, how can you communicate this to a child? I know that there's no recipe to do this, but what could be your thoughts about this? I love. I mean, I really study this disease, but children are marvelous. I mean, we need. I mean, child leukemia is something that can be cured. There are very few cases that cannot be cured, but the message that and this is the best thing that we can have in children is leukemia in terms of cancer, because it's the best of all other cancers. It is very difficult for parents to think that your child is going to die when you're told that you have leukemia, but the child has a different concept. So this is why, I mean, and if they feel better, they will, I mean, this child will be charming. So they don't have, they don't think about death. So therefore, the parents notice that you have to move on and that things will be all right. And this is a huge team. This is not just about the hematologist. We have a lot of support group. We have psychiatrists, psychologists, nurses, and we provide support to the parents when they hear about these sad news. And the hospital, I think, is amazing in this regard, and they provide a lot of support for those parents having to go through this difficult situation. So again, thank you, doctor, for your experience, your vast experience and knowledge shared today. The This is a recording that will be available in the Boomi channel at the end of March. We will have another session on another important topic, which is glaucoma. And and we do hope that you like this session. Thank you so much, doctor. Thank you to the hospital for the opportunity to share this the period of time. And with this is the end of our webinar. Thank you so much, doctor. Thank you all. Thank you.